Yeah, I've seen it. It's pretty good. Okay, I'll try. We have 16 lectures to go before the end of the term, so that's good. That means we have a lot of time. If you finish GI early, we'll go back to biochemistry. Now, 24 to 28 you have off. The 28th is your final exam, I think. Check on the website.
For March, you're saying, sir?
March 28th, not now. Not this month. Yeah. So March 24 to 28 you have off. Actually, you have off till April 4th, but 28 is the exam, so you have a week off to prepare for a final exam. And there's one more thing, guys. I don't know who did what yesterday. And I keep coming back to the same thing. You should be studying. When you study something, you know, you should be satisfied with that. Honestly, you do have to have the feeling of satisfaction. Now, there's two types of studying. You know, and please forgive me for me taking time away from lecture, but I have to keep saying that over and over. There's two types of studying. One is completion. You're worried about completing a chapter or a book or a task. The goal is just completion, not learning. When you mentally make this sort of, restriction on yourself or this type of goals, I'm going to finish this, I'm going to finish this, you strictly focus on what? On finishing. When you finish the task, you haven't learned much. And you're satisfied, you think you did the right thing. Try to do it differently. Your goal should be, I want to learn this topic only. You know, it's better than learning one topic a day than having 50 pages a day and then getting nothing out of it. But don't leave that topic unless you master it. So first, let's say we talk about, for example, we talk about the embryology. So it shouldn't take you more than 20 minutes to memorize those. So let's say 1 hour. So your task should be for the first hour today when you relax and eat and everything, I'm going to memorize and understand embryology of foregut, midgut, and hindgut. And then once you do that, once you memorize all the names and you can relate to them. See, memorizing is not enough. After you have done this, you have to talk to somebody, test yourself, and then ask questions that where you have to apply this knowledge. When you do that, you move on to the next topic or next lecture, what I'm going to do right now. Okay, if you still are not satisfied, then go read about it, about maybe a few pages here and there to strengthen your knowledge. Try to complete, try to do, for example, make a goal, set a goal. This is what I'm going to do today, 3 topics, and learn the topics. Okay, and when you start having this attitude of completing a task, it doesn't work. At least it hasn't worked for a lot of students. In my experience, it never works, believe me. It never works because you're just focused on completing something and your brain feels satisfied. Oh, I did it. It's like a job. You know, like they used to compare the communist economy and the free market economy. They say, oh, communist economy, you get paid regardless. Maybe in Canada, physicians, you know, this is a complaint against physicians or healthcare in Canada. They're getting paid regardless, whether they see 10 patients or 20 patients or they see you for 5 minutes or 10 minutes. So their money is guaranteed. They don't have any incentive to do what? To go beyond and do a little bit more to help you. Specialists there, sometimes you have a wait line for how long? 6 months, 8 months for simply CT scan. Imagine, CT scan. So they don't have incentive. You have to give yourself incentive, not task. Task is not important. Learning. You want to learn something and feel good about it and be able to apply it. Use a different technique than what you're used to. See, in high school and colleges, the attitude is completely different. You know, tomorrow you're going to be regurgitating the same thing. So if you just memorize something overnight, you're okay tomorrow. Here, memorization is not enough. It's application. You know, you have to act and feel like a real doctor, not like a robot. You know, robots don't get anywhere. So you have to be a physician from day one. Try to act like one and try to think like one and try to behave like one. And it affects you, believe me, it will affect you. When you think like that, you believe in self-fulfilled prophecy. I do. You know, whatever goal you make for yourself, you will accomplish it. You'll accomplish it. And then especially if you behave and act and think like it, it forces you to do so without stress. Without stress. I know these are difficult things because the most difficult thing for a human being is to change their behavior. And I'm telling you, look, we have certain attitude. All of us, including me. It's not like, you know, and some of you are probably much more superior in behavior and thinking, but nonetheless, we have shortcomings. Behavior is the hardest thing to change. you do have to change yourself. You do have to change yourself. It's not enough. And I'm telling you, it's not enough. You have to change the way you think. You have to change the way you behave. You have to change the way you study. And that will help you. I mean, my goal is one thing and only one thing. I only care for how you sit in residency. I don't care how you got there. I don't care, what you have to go through. As long as I have only one goal in mind right now is how I can get you to that point. Okay? And one thing I can do for sure is talk to you. It's free. It's easier for me to talk to you about it, to remind you. So hopefully with time we will also increase with resources and stuff. We can, like do other things to help you too. But for now, there's a lot of responsibility on you. A lot of it. Trust me, you have a lot of responsibility, and you have to take charge for that responsibility of your own actions and do things. If you're doing something wrong, come. And it bothers me, you know what? And it bothers me when students come here early in the morning, when I say every day, first 10 minutes, I would love to have questions. When every student comes in class and they have no questions, but yet there are no 100% on the exams. At least majority of you haven't scored 100% so far. I mean, you should think the same way. Why is that? When you read something, when you memorize something, you must come across questions. And if you get a solution to it, that's good. At least if you find something new, come and I'll share with the students. Let's be interactive. You always have to have questions. And if you have no questions, that means whatever you read, it didn't get through you. It didn't get through you. So it's going to be a constant struggle. Be patient. You will get there. And sometimes you'll score high, sometimes you'll score low. But as long as you are willing to change, as long as you're willing to study, as long as you're willing to learn, no one can stop you. Okay, so sometimes scores can be discouraging, right? Sometimes they could be overconfidence in you, like, oh my God, I can do it, so tomorrow I don't have to study. But my goal is I'm going to start putting tough questions to keep going, because otherwise, I've had these cases, sometimes students have easy exams, the next exam they bomb it. You have to constantly challenge yourself. All right? Okay. Now, let's move on to this structure called esophagus. And it's extremely high yield. Okay? There will be about 4 questions on the esophagus on the exam. I guarantee you. Whether you recognize it or not, that's a different thing. Okay. This tubular structure. What is the color of esophagus? I think this is correct. These people are so crazy these days. When I paid for this app, it used to have those tools, shading and coloring and stuff. Suddenly it disappeared. I'm thinking they want me to upgrade. Because why would it disappear if I pay for it? I mean, I used to be able to move this line, remember? Yeah. I can't do it no more. Wow. Crazy people. Oh, no good. So esophagus, know that it's connected to the stomach. Now, anyways, I'm not going to draw the stomach. So esophagus, let's talk about it. The esophagus. Okay. Esophagus is a tube, nothing more than a tube. Roughly speaking, about 20 centimeter in length. Roughly speaking, 20 centimeter in length. Those of you who are good in maths, so imagine how long that is. It's not very long, right? How many centimeter is 1 foot? No, how many? That's inches. Yeah. So it's roughly speaking about roughly 1 foot. Okay, so in tall men and in girls it's a little bit shorter. In tall men it's about 30. Yeah. Okay. So esophagus. Now, let's go again. It's nothing more than a tube, right? If something is a tube, what could be its purpose? Passage, transport. That's all. Every disease of esophagus, you should think about it. Obstruction to transport problem. That means swallowing. Esophagus cannot give you any other problem except swallowing, unless it expands and compresses the neighboring structures. But it's easier, isn't it? If you think of a tube is only for passage of food, because this is not airways, this is esophagus, so it's only passage of food. So the most you will complain of is difficulty swallowing, difficulty eating, painful swallowing, things like that. Okay, now, let's go into histology. So, esophagus has 3 layers. Okay, so if I were to cut, and that's true of the entire GI. if I were to cut it a cross-section of the esophagus, it would have a muscularis layer, a layer that's made of muscle. A layer that's made of muscle. The inside, which is a thin layer, even though here I'm going to do thick blue, is the epithelium. Okay, and then dark blue, let's use green. So we're talking about histology now, okay, not anatomy. Histology is, you can consider microanatomy. So green layer, and this is true of the entire GI tract. What does GI tract stands for? Gastrointestinal tract, which does not include pancreas, which does not include gallbladder, which does not include liver. When you say tract, it's a single tube. Liver stays out of it. It's a different organ. It's not tubular, right? It's solid, whereas stomach is tubular. Esophagus is tubular. Intestine is tubular. So gastrointestinal tract includes stomach, esophagus, and usually don't include esophagus. I do. So esophagus, stomach, and intestine, large and small, all of them, is a single tube. It's a single tube. Think of it as a single tube. Maybe one area is slightly dilated, the stomach. That's all. And it's folded some area. But if you stretch it, it will be a single tube. And it should look like this. If you really stretch it, it should look, let's say, esophagus. So this is esophagus, stomach, and then small intestine, and large intestine. There you go. If you stretch it. That's what it's a single tube. It's continuous. There's no separation. It's a single tube. If you stretch it from here to, where is Sam or Ahmed? Let's say you can stretch that much, all of the intestine. And I look through it, I can see them. I can see them. It will be a single tube. There's no discontinuation. A single tube. But because your abdomen is small, it has to be folded so it can fit there. Right? When it's folded, it doesn't look, you imagine, oh, it cannot be a single tube. But nonetheless, imagine it's a single tube. It has a cavity, up in space within it, and it has a wall. Okay? All right. Now this wall, the wall of this tube has layers. Green is known as serosa. Look, I'm talking about the entire tube now, not just esophagus, okay? The brown one is muscularis. And then blue one is mucosa. Very good. Mucosa. Overall, it has 3 layers. Serosa, muscularis, this should be S, looks like an R, there you go. And mucosa layer. Okay, let's start with, so which one is the innermost layer? Mucosa. Amazing, I love it, that's good. Now there's the thing, the mucosa layer is the thinnest layer and the most delicate layer. Let's talk about mucosa now. Mucosa has, so mucosa has the epithelium. It's made of epithelium. Okay, epithelium. The mucosa layer is epithelial layer. One of its layer is epithelium. Okay, one of its layer is epithelium. Can you guys see that blue? Yeah, you can. That's good. Now, we talked about epithelium. How many types of epitheliums are there? Overall 3, and then layer or single layer, right? Single or multiple layer. This epithelium is columnar. Simple. Columnar epithelium. But guess what? It has villi. Villi and microvilli. Now in esophagus there's no villi and microvilli. It's only in the stomach and intestine, especially intestine. Okay, so just a simple columnar. Now microvilli, villi and microvilli, this is only in the intestine. Let's put here intestine. Okay. In the esophagus, it's not simple columnar. Okay, guys? Please ignore this in the esophagus. In the esophagus is squamous. Let me just do esophagus. The epithelium will be squamous. Squamous. Now stratified squamous, many layers. Okay, stratified squamous. Stratified squamous. squamous. Okay, so that's in the esophagus. In the rest of, as soon as the esophagus ends, all the way to anal canal is the same epithelium, simple columnar epithelium. And the intestine has villi and microvilli. Okay? Again, in the esophagus is stratified squamous. Beyond that, until anal canal, and anal canal becomes squamous again. Between the anal canal and esophagus is what? Simple columnar epithelium. Simple columnar epithelium, yeah.
Yeah, I think you said when we were talking about it for the stratified squamous, it also did have the microvilli in the esophagus.
They have what?
It also did have the microvilli.
No. Does not have villi and microvilli. No. Okay? No. Okay. All right, so now, number one, so mucosa should have epithelium. And the epithelium in esophagus is different than in the GI or in the intestine or stomach. Is that okay? Just remember that. Okay, so again, I'll discuss the epithelium of each organ separately. So number one, serosa has epithelium. Epithelium is always sitting on a basement membrane. All epithelium requires basement membrane or base, I mean, you can call it base membrane or basement membrane, so just a basement membrane. Okay? All epithelium will have basement membrane, all of them. The basement membrane is like a solid cement that holds the epithelial cells tightly together. So that's the purpose of the basement membrane, to hold the epithelium together. Okay? Okay. Now, the epithelium is avascular, has no blood supply. Remember that. It has no blood supply, no nerve supply. Okay? So that's mucosa. And then we have submucosa. Okay, submucosa. Submucosa. Submucosa would have glands. Okay. Sometimes they include the base membrane in the submucosa too. So it has glands. It's vascular, and here you have nerves too in submucosa, nerves. See, the entire GI has its own nervous system. Okay, it's known as myenteric plexus. Okay, sorry, enteric plexus. So nerves, it's known as enteric plexus. Now, in the submucosa, you have two types of plexus. So in submucosa, do you remember anybody? What is the nerve plexus in the submucosa compared to muscularis mucosa? Meissner's, very good. And how about in muscularis propria? Myenteric, muscles myenteric, yeah. Good job. Or Orbach. That's correct too. Good, just have two names. Okay. So in submucosa you have glands. These glands secreting solutions like mucus. So let's say mucus glands. They produce mucus. So does this epithelium. The epithelium, again, is usually for absorption, secretion, and so forth. Okay? All right, submucosa we're done with. Now, after this we have muscularis mucosa. So, muscularis mucosa. Muscularis mucosa. The next layer is muscularis mucosa. And this is actually the one that has Meissner's plexus. Muscularis mucosa. Now, all mucous glands should have muscle, smooth muscle. It's always smooth muscle. To do what? To contract so you can squeeze things out. You know, like a pipette? When you squeeze it, solution can be pushed out. So the glands act like that. If they come in contact with hormones and stuff like that, so for example, how could you push things out of cells so it can be increased in the GI tract or in the intestine to help you digest? So they have to push out, squeeze out. So those glands will squeeze out and they will secrete their solution. Okay, so they need muscles to cause a contraction. Muscularis mucosa. So muscularis mucosa is always smooth muscle. Always, always smooth muscle. Always smooth muscle. Let's move on to the purple thing now. Muscularis. Muscularis have two parts. We discussed one of them was muscularis mucosa, and the other one is muscularis propria, the proper muscle. Propria. So muscularis has two parts to muscularis propria and muscularis mucosa. Okay. And this is primarily for contraction. The function of this is contraction, which is the middle layer, muscle layer, middle layer. It's for contraction. In here you will find myenteric plexus, which is nerve supplies. Also they're known as orbach. Yeah. Okay, so the propria is actually, so there's two types of muscles, okay, in terms of locations. Muscularis propria is the true proper muscle, which is thick, many layers. And the muscularis propria is responsible for, do I say contraction? Yeah. It's responsible for movement of food.
So mucosa is just to secrete.
Mm-hmm. And for movement to occur, we need what? Peristalsis. Okay. Now, muscularis mucosa, on the other hand, is not responsible for movement. It's a so thin and small muscle cells. They're responsible for secretion. Secretion and secretion and secretion. So they only surround the glands. Okay, so they just squeeze glands like what I talk about pipette. Okay, so that's what it's for. Now, remember that now we have two nerve plexus. They're both known as enteric. Enteric means intestinal. Okay, so plexus in terms of, they're both known as enteric. Enteric means intestinal related. So one is myenteric. My means muscle, which is only found in the smooth muscle layer, the muscularis propria. Myenteric plexus are located where? In muscularis propria. Meissner's plexus are located in submucosa, especially in which area of the submucosa? Muscularis mucosa. Okay, so they're different. Each plexus have different function. Myenteric plexus is for peristalsis. Meissner plexus is for secretion. Okay, if you don't know, just write it down so you can remember it. Myenteric plexus for peristalsis or movement. Myenteric plexus for peristalsis or movement of what? Of food particles or stool. Now, Meissner plexus only for secretion of fluid and of mucus. Okay. Okay. Serosa is made of connective tissue. It's there for protection. Overall, let's not think about the three layers overall. Serosa is only for protection. Only for protection. It's a rigid layer, protection, the external, the outermost layer. Muscularis propria, or just say muscularis layer. The muscularis layer is for what? Peristalsis, peristalsis, peristalsis movement. Mucosa layer and submucosa, both of them are for secretion and absorption. Secretion and absorption. Secretion and absorption. Done. If you think about it overall in that context. Nina.
What's the other part of the muscularis mucosa? One was propria, the other one is what?
Muscularis mucosa has only one layer. That's an layer by itself. Yeah. So mucosa has muscularis mucosa and mucosa and submucosa, you know, in that sense, yeah. The mucus layer. So if you say mucus layer is the layer that's in direct contact with fluid in the intestine. And it has immediate mucosa layer and it has submucosa. Submucosa has muscularis mucosa as well. Okay, so this is true of the entire intestine, entire stomach, and in the esophagus. Okay, now we can go to esophagus. So, depending how many layers of muscle cells do they have. So let's talk about esophagus first. Histology of the esophagus, and then we'll go to anatomy, okay? This tubular structure has three layers. Same thing as before, mucosa, muscularis, and serosa. Serosa has about 2-3 layers. They're mostly made of collagen and fibrous tissue. Muscularis has 2 layers. You can think of them in muscularis propria and muscularis mucosa. Mucosa has, the mucus layer has submucosa and mucosa. And then they have basement membrane in between them. Okay. Now, the esophagus, we're going to divide them into 3 layers. 3 areas. Proximal esophagus. If it's 3, we're going to call this proximal 1/3. We're going to call this middle 1/3. And we're going to call this area distal. I feel like I divide into 4. Distal 1/3. Okay. Again, this is not division anatomically. It's just to make life simple. For you guys, complicated. Sorry. More information, more complication, right? If more information is more complication, why do people want to know everything? They want to know everything. Sometimes knowledge can be, too much knowledge can be painful, you know? So sometimes you just ignore it. You don't have to know everything. I don't know why I'm talking like this, but anyhow. All right. Proximal 1/3, middle 1/3, distal 1/3. That's esophagus. Okay. The serosa, the mucosal layer is always, again, the epithelium is always stratified. Whoa. Stratified squamous epithelium, which is the innermost layer. Okay, the epithelium of the esophagus is always what? Stratified squamous epithelium, and that's done. As soon as the esophagus comes in contact with stomach, this junction between stomach and esophagus, there's a sudden change. Slowly changes from what? Squamous to columnar. This is on a transitional zone. We'll come to that. Extremely important area. A lot of diseases. Okay, but for now we're talking about esophagus. The epithelium of esophagus is squamous, stratified. Why do you think it should be? Your question first.
Does it have cilia on the right?
No cilia. No.
There's no esophageal cilia?
Trachea, yes. Esophagus, no. Yeah. There shouldn't be cilia. There should not be. There's no purpose. What is the purpose of cilia? Maybe it will make sense. To move particles. What kind of particles? Now, do you ever eat like dust particles in the esophagus? No, you eat large food particles, and that cannot be moved by cilia. Think about it, like when you eat a bowl is this big, cilia is microscopic. Can they move a large particle like this? No. So number one, physically it's not possible. Number two, you have peristalsis. The major movement of esophagus, it's a collapsed tube. It's a collapsed tube. It's almost like, I don't know if you guys seen when they make hot dogs. I don't know, I watch some weird shows. They make hot dogs, so they'll put a meat and then they will squeeze it. This is peristalsis. Think about it. This is a tube. If the entire thing is collapsed, the only air that will be dilated where you have the food bolus and keep moving along. So peristalsis is what moves food, not cilia. In trachea, which is open, because you cannot squeeze it, and there's dust particle, you need cilia. Okay, to move mucus, not in esophagus, no. Cilia should be only found in the trachea and fallopian tubes, uterus, that's about it, or maybe vas deferens. Okay, nowhere else. All right, just trust me. Okay, just trust me for now.
Open tubes, not collapsed tubes.
No, it's collapsed.
No, I'm talking about cilia. It's a
Yeah. Cilia, yeah, it has no purpose to be found in the closed tubes where there's large particles, yeah. See, if you need a cilia the most, you'll need it in the intestine. Even there you don't have cilia. What do you have? Villi and microvilli. Okay, so you really don't need it. Anyways, so stratified squamous epithelium is the epithelium of esophagus, okay? That's one thing. Now, so that's the innermost layer, and then you have the muscle layer, right? Muscle layer. See, in the esophagus, there are two muscle layers. One is circular, and the other one is longitudinal. Circular and longitudinal. So there's two layers. Circular. I don't know if this will help you in anything. So circular, and then longitudinal. Longitudinal. Circular causes the esophagus to squeeze, contract in this direction. The lumen will be expanding and contracting. Longitudinal to make it shorter or longer. Okay, so that's why it has only two muscle layers. But now, in the proximal 1/3 of esophagus, the muscle is mostly skeletal. In the middle 1/3, in the lower 1/3 is mostly smooth. We're talking about muscle cells. You have three types of muscles: cardiac, smooth, and skeletal. Cardiac is only found where? In the heart. Skeletal is only found where? Attached to bones. All internal organs are smooth. All internal organs. So you have to, by definition, do that. Okay. Now the distal 1/3 is attached to what? There's cartilage. So it's skeletal. So again, you won't be confused. cartilage here.
Proximal.
Did I say what? Sorry, the proximal. Okay, so it'd be attached to what? Cartilage, cricoid cartilage, thyroid cartilage. Okay, so it's only skeletal here, primarily skeletal, primarily smooth. In the middle, what do you think? Mixed. Now, how is that significant? Well, skeletal muscle is in your control. So here you regulate swallowing. You have to decide to swallow. As soon as you go to smooth muscle is not in your control. It's under autonomic control. You cannot stop anything. It will go by itself. Okay, it will go by itself. So in the skeletal regions, now, the cilia of in pharynx, in nasopharynx, there is cilia, but that's not considered esophagus. If people consider that, they're making a mistake. Nasopharynx, which is the esophagus and trachea coming together, separated by epiglottis, this nasopharynx area, you will have cilia. Okay, we'll talk about that. But now, esophagus, you have proximal, middle, and distal. Know at least the histology in terms of smooth muscle and skeletal muscle. Extremely important. Okay? All right. That's one thing. So we know the epithelium, we know the muscle, and we know this. Good. Next thing I want to do, so in the upper esophagus, there is a slightly thickening. There is a thickening of this muscle. And that's the upper esophageal sphincter. Upper esophageal sphincter. Upper esophageal sphincter. And then there is thickening of the same muscles, smooth muscles, right here. It just, this circular muscle is the circular muscle only. Okay, so the sphincters are only thickening of what? Circular muscle, not longitudinal. So let's just say this is lower esophageal sphincter. And what is this? It is rings upon rings, many rings. Many layers of circular muscles. Okay, slightly thicker, so it looks like a ring and act like a sphincter. Sphincter is as if it's a valve. It can close and open. It can close and open in response to food. Now, in the proximal esophagus, when you have this thickening of muscle, it is skeletal or smooth? So it's in your control. There you can control swallowing. In the lower esophagus, you can't. It's under autonomic control. Okay? So LES, you should know, and you should know UES, upper esophageal sphincter and lower esophageal sphincter. Okay. Further, talking about these things. Okay, so let me talk about one more thing, and then if this is esophageal tube. Okay, let's talk about the relationships in terms of what is related to esophagus. What's inferior to the esophagus? Stomach. Okay. Does anybody know what is the beginning of esophagus? How do you know what landmarks would you use for the beginning and end? Where does the esophagus start? I have to calm myself down sometimes, just like a car with no brakes. Huh? Where is the beginning of esophagus? Okay. Where's epiglottis? Where is the end of esophagus? Okay, LES is correct, stomach junction is correct, and diaphragm is correct. Okay, so let's put here a diaphragm. I haven't said anything they're saying, so just ignore them for now. Sorry. Now the landmark we want to use, the best landmarks are what? Vertebrae or ribs. So 12 eggs, 1 sperm. Yeah. Yeah. Okay. That's correct. That's correct. So this ends with T12. Okay, the vertebrae T12. Actually, it's T10, T12, correct. You know, T12. Aorta is at T10. So the end of esophagus is at the level of what? Which vertebrae? Thoracic 12. Thoracic 12. Okay, so just remember this. Let me just remove the diaphragm just to make this So the end of esophagus is at level of T12. Thoracic vertebrae 12. The beginning should be what? Half of that. C6, yeah. Yeah. T6 is right here. At the level of the heart. Okay, so please remember, about roughly speaking 25 centimeter in length. So the beginning starts at C6. C stands for cervical vertebrae. Cervical vertebrae. Okay. Are we good with this? Let's move on. Okay. Now you know that, all of you know that abdominal cavity is separated from thoracic cavity by a dome-shaped structure known as diaphragm. So this is the diaphragm. Okay, so diaphragm. That means there should be an opening in the diaphragm, right? For the esophagus to pass through. Yes, there is. And we will call this esophageal hiatus. This opening, esophageal hiatus. Hiatus means an opening. H-I-T-U-S. Hiatus. Not hating. Doesn't mean hating us or you or this. Hiatus. Okay. Honey, why are you looking at me like that? Here you go, I'll spell it. Okay, so hiatus. Esophageal hiatus. In the diaphragm, you should have how many hiatuses? Three. One is for aorta, vena cava, and esophagus. Very good. So esophagus is at level of T12. The opening. You could, because that's the end of it. And how about aorta? How about vena cava? 8. Good job. Good job. Actually, aorta, you can say 10. Aorta is slightly at the level of 10. So it's 10, 8, 10, 12. Okay. We're going to talk about the relationship anyway, so we're getting there right now. We're getting there right now. Okay, so now, you see the diaphragm? The diaphragm is a strong muscle. Is diaphragm skeletal muscle, smooth, or what is it? Or cardiac? Or alien muscle? Thank you. So the diaphragm, the muscle called diaphragm, actually can constrict. It constricts, so when it contracts, it opens up. And you can have passage of food easier. But when it relaxes, it will constrict it. So it also, the diaphragm also add to the LES activity. Remember that. This area here, this should be usually closed, right? Number 1 is LES. Number 2, diaphragm. Both contribute to what? To closure of the lower esophageal area. The junction between esophagus and stomach. Why? So there's no regurgitation of what? Food or acid. Okay? So LES should be always closed. The diaphragm should help in that closure. LES will only open up when food comes in contact with it. So it has contact receptors. As soon as food comes in contact, it's almost like you knock on a door and it opens up. Or you know what, those doors that are automatic? As soon as you step in, same thing. As soon as the food comes in contact, it opens up. Yeah.
Does the contraction for these have anything to do with the opening for LES?
Speak up, please.
Does the contraction for the UES have anything to do with the opening for the LES?
No. They're independent. Yeah. Okay, they're independent. People can make assumption that, you know, though it's not true. Completely different muscles. LES directly responds to acetylcholine, number 1. Parasympathetic supply, I'll tell you. Plus contact, 2 things. 2 things is what that will open this area. One is stretching of the esophagus, which is again release acetylcholine. Okay, and the second thing is contact with the LES, with food or water or liquid, whatever. Okay. And the pressure too, because as it gets squeezed, the pressure builds up towards it. Okay, so we want to talk about LES. Please remember LES. LES should be closed. The diaphragm should contribute to that closure of the lower esophageal sphincter as well. If you have dilated esophagus, again, LES is not so good. So 2 things. Both are important for preventing acid reflux. Good? Okay. Let's talk about esophagus. Where is the esophagus located now? In the thoracic cavity, not in the abdomen. Even though it's a part of GI tract, right? Even it's a digestive organ, it's not abdominal structure.
Is it digestive organ?
Huh?
Is it the digestive organ?
Yeah. It is a digestive structure, maybe not organ structure. Okay, because it's involved in digestion or passage of food. Okay. So now remember this, esophagus is part of the digestive system, but it's still located where? In the thorax. Oral cavity is part of the digestive system too, but it's not located in the abdomen. So usually when students think, they think digestive system only abdomen, abdomen, abdomen. No. Teeth are part of the digestive system. Tongue is part of the digestive system. Oral cavity is, and so forth. Okay? And you have salivary gland here, here, and here, and here. Okay. Let's focus on esophagus for now. Now, esophagus is located in the thoracic cavity. The thoracic cavity, if I were to draw CT scan, when you look at CT scan, you see you have pleural cavities. The peripheral are pleural cavities right here. Pleural, PC, pleural cavity. These areas are belonging to lungs. So let's say this is one lung and this is another lung. Let me highlight it for you so we can differentiate them. These are two lungs. Okay, two lungs. So I'll put left lung and right lung. These are pleural cavity. It's still thoracic cavity, right? The entire thing is thoracic cavity, but within thoracic cavity we have three cavities. One is pleural cavity, two of them, that's two, and the third one is mediastinum. This space, the clear space, is known as mediastinum. Mediastinum, mediastinum. So I guess I should slow down. Very good. Pleural cavity. This is also pleural cavity. How many pleural cavities do you have? Two. What does cavity mean? Space, empty space, an opening, right? Opening. So you have left and right pleural cavities. And pleural cavity has what in them? Lungs. Lungs. They're not technically empty. There's lungs there, right? Okay. Mediastinum, this area known as mediastinum. So imagine you take this room and there's no chair, there's not us, it'd be just as open space. So you can imagine it as open space, the thoracic cavity, but still there are organs in there, right? So in the mediastinum you have heart. You have heart. So mediastinum is divided into imaginary mediastinums. Okay, so what are some mediastinums? Let's look at it this way here. There is, good. So let's say this is the front, so anterior mediastinum. And there should be the back, posterior mediastinum. Let me spell mediastinum for you, okay? Mediastinum. Okay. Okay, so, and then you have the middle mediastinum, right? The middle mediastinum, right in the middle. The middle mediastinum is all heart, nothing else. Just keep it simple. The middle mediastinum is all heart. And we'll do that in cardiovascular system. So, for now, just know that here is the heart. The middle mediastinum, this is the heart. Now, which means what? In my diagram, it's not perfect, so if I were to make this heart, okay, so here you go, this is the heart, and heart is slightly deviated towards the left, right? Now, in reality, I think we can do lungs in blue, because this should be blue. It'll make you like it more. There you go. So technically, the lungs are direct contact with the heart, like this. So the right lung is bigger than left lung because of this. Okay, so this would be more appropriate. Now, we're not going to talk about anterior mediastinum. We will talk about which one? Posterior mediastinum. Excellent. Why? Because that's where the esophagus is located. In posterior mediastinum, okay, so let me see if I can do this. Imagine this is the vertebral column. Okay, and then you have the back muscles. Of course, you will have the ribs and back muscles around the lungs, right? Ribs and muscles around the lungs, so this dark. Although on CT scan, they look light, right? They look bright. Please remind me so I bring some CT scan for next time, because it's important. So here is the spinal cord, and this is the spinal column. So between the spinal column and heart, you have posterior mediastinum, behind the heart. Behind the heart, okay? Now there, we have structures. On the left side of it, there is aorta. There should be aorta. Okay, going across. If you cut it, you're going to see a dot, right? If I cut this pen and you look at it, you're going to just see the circle. That's what I did. This is CT scan, horizontal section of the body at this level. Let's say this is level T6 or T3, T4, somewhere there. And then you would have vena cava on the right side. Slightly anterior. Vena cava is a little bit more in the front. You know, vena cava. And aorta is actually more rigid. Red. I need red. Aorta is more rigid, so it'll be open, perfect, beautiful circle. Vena cava is not so rigid, so it might be a little bit elongated. It might not be. It will look more like a collapsed. Yeah, a little bit elongated like this. Esophagus. This will be esophagus. Okay, so now you should know the relationship of esophagus. Okay. Depending where you take the CT scan, if you take it higher up, in front of the esophagus should be trachea. But you get the idea of posterior mediastinum? The structure of posterior mediastinum are what? Vena cava. Which vena cava? Inferior and superior. Superior is more in the superior mediastinum, but you know the posterior mediastinum you primarily will have inferior vena cava. Okay. Although it might be, look, if this is the heart, inferior vena cava reaches that far. So it might not be even there, depending where you take the section. Okay, so it is okay for me to delete it. I'll just do that not to confuse you. So you're going to look for those now. So I hope you understood this part. Now we're going to go over some structures. In the upper esophagus, in the upper esophagus, in the upper esophagus, in front of the esophagus, you will have what? Trachea. Trachea. Slightly in front of it, and then the bronchus. Which bronchus will be more related to it? Okay, it should be left bronchus, yeah. It should be, yeah, that's correct. Okay, so that's one thing. And then here, so look, in the upper half of the esophagus, in front of it is one structure known as trachea. Okay, in front of the upper esophagus, there you go. You have what? You have trachea. You have trachea. So if I were to do esophagus, let me do this. Esophagus is right here, behind it. Here you go, it's behind it, right? Behind it, and then it slightly deviates like this. So this is the esophagus. Upper half of the esophagus, in front of it is trachea. Lower esophagus, in front of it is the heart. Okay, is the heart. Now write this down. Yes, it's true, heart is in front of the lower esophagus, or smooth esophagus, smooth muscle esophagus. But heart has how many chambers? 4. The chamber that's in direct contact with lower esophagus is left atrium. Left atrium. Write this down. It's extremely important. Don't forget. Left atrium. Left atrium. Left atrium. Left atrium. Okay? I just don't like my upper picture. Let me erase this and draw a better one. Left atrium. Trachea is in front of the upper esophagus. Okay? And then trachea will divide and it give you the left main bronchus and the right main bronchus, right? Okay, that's good. Guess what? You see the left main bronchus? It pushes against what? Left main bronchus. Left main bronchus. It's constricting. So in that area, sometimes the bronchus, bronchogenic cancer, or something like that. I'll ask you those questions, but please tell me this. You see the left main bronchus? You see its relationship to esophagus? Please remember this part. Okay, so this area in yellow. The area in yellow right here, this area. Please understand this area. And the area of the esophagus related to the left atrium, you have to memorize this area and know them. What is their clinical significance, okay? All right. So anterior to the esophagus is the heart and trachea. Heart and trachea. Anterior to the esophagus is what? Heart and trachea. Also, arch of aorta. See, aorta loops around the bronchus, right? Aorta will loop. So this is aorta. It loops around the left main bronchus. And it will go behind it. And then it will go behind it. So this is aorta. And we'll go behind it. Now I'm going to use aorta a little bit darker and use this one. So it goes behind the heart and behind the esophagus. So that's this aorta. Okay, and it'll go like this. It crisscrosses. So now esophagus is between what? Thoracic descending aorta and left atrium. The lower esophagus, right? The lower esophagus will be between, against the wall of left atrium. In front of it, behind is what? Thoracic descending aorta. See, aorta has three sections in the thoracic region. Ascending, going up, and then the arch, and then descending. Ascending aorta is actually in front of the esophagus, right? Arch of aorta loops around the bronchus, but descending aorta is behind the esophagus. Okay? Aorta just goes loops around. You know, like those canes, the Christmas canes, the colorful ones? Think of that arch of aorta and aorta. If you put it in an angle that goes backwards, you know how it will look. Let me show you. Let's say that here is the esophagus. Just to make one more attempt at this. This is esophagus. In the upper part, you have trachea in front of it. Okay? Trachea in front of it. And as a matter of fact, trachea comes like this too. Just to show you. It is in front of it, but in the lower part, it's the bronchus that goes across like this. So that's trachea. Left bronchus. And then here is the heart, right? And aorta will start here. Aorta starts here, loops around, and it comes, and it goes behind the esophagus, like this. Okay, so know the relationship of thoracic aorta when it comes to esophagus. What's in front of esophagus in the upper region? Trachea. In the lower region, heart. What's behind the esophagus? Descending thoracic aorta, that's all. And further, we have one more thing. There's a duct, a lymphatic duct known as thoracic duct, which is also related to esophagus on the left side. Sorry, on the left side. And this will actually empty into the jugular vein and subclavian junction. The junction of subclavian. So this is subclavian, this is jugular vein. The junction right here. And that's where it will drain. It will empty into this. That's the lymphatic duct. Thoracic duct. So for now, all I'm telling you is what is related to esophagus. In front of it is the heart and trachea. Behind it is thoracic aorta. To the left of it is what? Thoracic duct. Thoracic duct. To the right of it is vena cava. Okay? Are we okay so far? Let's go further. Now vena cava is not much, so that's not a big of a deal. But to each side of esophagus you have sympathetic chain. Each side of the esophagus. Please write this down. To each side of esophagus, I'll use yellow for that. On each side of esophagus, you have, that's not yellow, you have sympathetic chain. And that's sympathetic nervous system. So they'll be going like this, sympathetic chain. And they'll give this plexus around it, nerves, to supply the esophagus. Also, you will have 2 more nerves.
Isn't the plexus from the vagus nerve?
Yeah, it's both. It's both. Yeah. So now, on each side of the esophagus, anterior to the esophagus, not posterior. Posterior is what? Sympathetic chain. On each side of the esophagus, slightly backward, posterior is sympathetic chain. Anterior, in front of the esophagus, you have 2 vagus nerve on each side, mostly anterior. For example, if this is esophagus, slightly in front of it like this, that would be the 2 vagus nerves, left and right vagus nerves. Okay, and then recurrent laryngeal nerve. Write this down. Recurrent laryngeal nerve. Recurrent laryngeal nerve are related to the upper esophagus. Upper esophagus. Upper esophagus. So, again, whenever you want to learn anatomy, you have to look at pictures. Otherwise, it's difficult. Okay, it does take too much time. If you look at pictures, it takes a few seconds. You will know it. Okay, the question is now, once we know these anatomies, you're like, why are you telling me that? Because they can cause problems. It can produce symptoms, so we have to know them. Okay, so let's start with those. What time is it? Should we take a break or continue? 10:20? How long are we going for? Oh, really? Okay, let's take a break. Okay.